Welcome. It's 7 o'clock and you're here at St. Francis for a very uplifting topic, right? I'd like to get us started with just a little note about our gospel today. Jesus says to Simon, remember this gospel is about the woman who washes Jesus' feet and doesn't stop kissing them because her debt is forgiven. She just loves him, right? And Jesus' first words is, do you see this woman? So many of us, sometimes we feel like nobody sees us, nobody cares, right? That's usually what's going on in our brain when we sin. Like, nobody sees me, nobody cares. Do you see this woman? Wow. And then, just before that, in Corinthians, the reading said, St. Paul wrote, by the grace of God, I am what I am, and his grace to me has not been ineffective. So you are a gift. Thank you for being here tonight. And we just want to get started with a prayer. We are live. So this is being recorded. There are 3 cameras. 1, 2, 3. And this will be available on YouTube. So euthanasia and assisted suicide, because there is legislation pending in Lansing, okay, to legalize these things that we would rather not see legalized, right? So today, we have with us 3 guests, and before we introduce them, I'd like to start us out with a prayer. In the name of the Father, and of the Son, and of the Holy Spirit. Hail Mary, full of grace, the Lord is with thee. Blessed art thou among women, and blessed is the fruit of thy womb, Jesus. Holy Mary, Mother of God, pray for us sinners, now and at the hour of our death. Amen. Father Almighty, your majesty, we come before you and we praise you. We give you glory. We thank you for our life, for the lives of so many of our relatives and friends who may be elderly and vulnerable. We ask you to bless us now with wisdom, Sophia, right? Bless us, strengthen us, that we may be witnesses to your great friendship. And we ask this in Jesus' name. Amen. In the name of the Father, the Son, and the Holy Spirit. By the way, you can talk at your tables, and the people on YouTube can't hear you at all. Only what's said into the microphone will be heard on the recording. So we have 2 microphones. If necessary, we can go around and, if someone wants to be heard on the recording, that would be great. So our first speaker, I believe, is Genevieve Marnon. Did I say it right? Marnon. Yeah, Marnon. Legislative Director of Right to Life of Michigan, drove all the way from Lansing. Welcome.
Sorry, I'm a little shorter than he is. I'm a little shorter than everybody is, so there's that. Okay, so can everybody hear me okay? Good. I tend to talk with my hands, so if I get away from the microphone, yell at me if I'm being too quiet. But I want to start by just real quick defining a couple of terms. This says euthanasia and assisted suicide. And there is a difference, technically speaking. Euthanasia is an active process where the doctor will inject you with a lethal injection. So you are a passive recipient of the lethal drugs. Whereas assisted suicide, you actively take the lethal drugs in order to kill yourself. So I'm only saying that because in the United States right now, euthanasia per se is not legal like it is in other states, in other countries like Canada and in places in Europe. The bills before us in the Michigan legislature would legalize assisted suicide, whereby the patient would be given a prescription of a cocktail of lethal drugs, they would go home, and they would take it on their own by themselves without a doctor necessarily present. Just so we're clear on the different terminology, because I think what happens too is proponents of assisted suicide love to banter around different terms, death with dignity, medical aid in dying, and all of these euphemisms to really kind of blur what they're talking about. So I want to be very clear what we are talking about. So currently in the state Senate, there is a 4-bill package. There's Senate Bill 678, 679, 680, and 681. You do not need to write this down. There's lovely handouts right up there for you if you don't want to take notes. I mean, feel free to do so, but I brought flyers for you where it breaks it all down. So, so we're going to go through each of the bills real quickly and kind of just the mechanics. And again, I know I'm doing the boring part, but I'm a legislative person, so that's kind of what I do. So 678 was introduced by Senator Sam Singh from East Lansing, and this is not his first attempt at trying to get assisted suicide legalized in the state of Michigan. He and another representative introduced them a few years ago when he was in the House. The Senate Bill 678 declares it in the bill, in law, that assisted suicide is not suicide. So we're clear, that's what it says. So legally speaking, assisted suicide is not suicide according to the bills. It actually prohibits insurance companies from denying or limiting your coverage if you intend to commit suicide using lethal drugs prescribed by your doctor. So, I'm not exactly sure how an insurance company would know that. It's not like you're going to call up Blue Cross and Blue Shield and go, hey, you know what, I plan to die by lethal drugs prescribed by my doctor. You're not going to do that. But they put this kind of language in these bills in order to make it look like they've got these safeguards. You're not going to be denied coverage. Well, your insurance company isn't even going to know that you plan to commit suicide using lethal drugs. And frankly, it's more apt that the insurance companies will limit your coverage if you don't want to end your life prematurely, right? As we've seen in some other states, coverage is denied for life-saving treatment, and in the same letter, people are given the option to have assisted suicide drugs with a $1.20 copay. So, but I just wanted to point that out, that language is in the bill, and it's designed to look like a safeguard. Senate Bill 679 is introduced by Senator Kevin Hertel from St. Clair Shores. Incidentally, his brother is Curtis Hertel, the brother of the Department of Health and Human Services director. Interestingly enough, the director of Health and Human Services, Elizabeth Hertel, actually chairs the Anti-Suicide Commission in the state. You can't make this up. And it's her brother-in-law that introduced one of these bills, but whatever. So Senate Bill 679 provides financial penalties for individuals who forge, conceal, or destroy a request for lethal drugs or coerce someone into requesting them. There's a penalty that's a felony, and there's up to 20 years in prison. So again, really good, solid safeguards, right, in these bills. At least that's what it sounds like. But these supposed safeguards aren't necessarily ever going to be discovered because we have things like telemedicine and electronic requests. So the doctor may never actually lay eyes on the patient. You're on a webcam, a Zoom meeting, and someone behind you is threatening that if you don't do this, XYZ things are going to happen, right? And you'll never know. That's just one example. I mean, I could come up with a million more, but just to give you an idea of, be careful when they say there are all these safeguards, and it looks like that language is in these bills. Senate Bill 680, introduced by Veronica Kleinfeld. I'm only mentioning the names in case if some of you came from any of these areas. She's from East Point. In her bill, it prohibits sanctions against the license for doctors or medical providers, they don't necessarily have to be doctors, who prescribe assisted suicide drugs. So the state can't sanction your license. It allows pharmacies to disclose prescription information to the Department of Health and Human Services. Again, that sounds like they're going to keep really good track of it. That sounds really great, but it's passive. It doesn't require it. It allows it. So just, again, these are these nuances in legislation that when you read it, on the surface it sounds really good until you really dig into it. they're not really going to be necessarily tracking these drugs. In fact, there are no official drugs. Did you know that? The FDA has not approved any drug cocktails for lethal prescriptions for people. It's a combination of drugs. I'm sorry, am I stealing your thunder? I don't want to get into, this is the doctor, so I don't want to step on his toes, but there are no FDA approved cocktails for assisted suicide drugs. So kind of doctors make it up on the fly. So you may get a prescription in a pharmacy and they're not necessarily going to go, oops, this is assisted suicide drugs, we better tell the department, right? And then the last bill is 681 by Mary Kavanaugh from Redford, and this is the main bill of this 4-bill package. The others are what they call trailer bills. This is the main one. This is the one that defines a new act called Death with Dignity, and it repeals Michigan's long-standing prohibition on assisted suicide. How many of you remember Jack Kevorkian? Raise your hands. Okay, we are the home of Jack Kevorkian, and of course we were one of the states that went out immediately and passed a law prohibiting assisted suicide in our state. This bill would repeal that law. It also declares, again, in a second bill, that assisted suicide is not suicide. Just so we're really clear on that. It's in the law. It's illegal. It's not suicide. It's just assisted suicide. And it provides immunity for those who participate in assisted suicide, and it states that healthcare providers are not required to participate. So our doctor here would not be forced to prescribe lethal drugs to his patients if he didn't want to, for now. Yes, for now. And it also allows places like Catholic hospitals to say, my physician cannot perform or prescribe assisted suicide drugs on my premises. However, if you have a doctor who's moonlighting at a clinic doing assisted suicide prescriptions, but also works at the Catholic hospital, you can't fire him. So, just FYI, those are the bills in a nutshell. And there are some concerns with Michigan bills, like I just mentioned, but I'm going to go over a couple more. There's no supervision required with these drugs. So once a patient requests these drugs and they receive the prescription, they go home with them and they put them in their medicine cabinet or in their top desk drawer or wherever. And now mind you, these are drugs designed to kill people. They are lethal, right? No oversight. You don't have to tell anybody you got this prescription. You don't have to be in the presence of a doctor when you take these drugs. You don't have to take them in a certain time frame. A lot of people will ask for these drugs just as a maybe, just maybe, if I need them, I'll have them if I decide I want to use them. But many times they die before they ever take them. In fact, in Oregon, it's a pretty high number of drug prescriptions that never get taken. What happens to those drugs? I don't know. Did I mention we're in the midst of an opioid crisis? And yet, a lot of these drug cocktails contain opioids. So, moreover, if you don't use them right away, maybe you just wanted them as a safeguard and you're not actually planning to use them, but you got a tired caregiver who's just ready for you to be gone now, crush them up, stick them in the food, nobody's going to know the difference. There is no psychiatric evaluation required. Now, it sounds really good in the bills. If you read it, it says the doctor can refer you for a psychiatric evaluation. They may refer you. They are not required to refer you. And in Oregon, the state that had the longest track record with assisted suicide in the United States, they legalized it in, I think, 94? 94. So, like, basically, 30 years ago. Only 3.3% of the patients who received assisted suicide drugs in Oregon ever had a psychiatric evaluation. No residency requirement, which will open the doors for Michigan to become a suicide tourism state. People will want to come here to die like they do in Switzerland right now, for example. Patients who are not actually dying can receive lethal drugs because you just have to qualify. It just has to say that it would be likely that you are going to die within the next 6 months. Well, if you are an insulin-dependent diabetic and you say, well, I'm just going to quit taking my insulin, what's going to be your prognosis? You're going to be dead within 6 months if you quit taking your insulin, likely. That makes you now eligible to receive assisted suicide drugs. If you're an anorexic and you say, you know what, I'm not going to eat. Now you automatically qualify for assisted suicide drugs, even though you're not terminally ill. So these are some concerns that we have with the bills that are just like right on the face. Now, I want to get into the political angle because kind of what I do, and it would be remiss of me to not talk about it. But right now, for the first time in 40 years, the Michigan legislature has a trifecta, which means there's a Democrat majority in the House, in the Senate, and in the governor's mansion, which means without a single Republican vote, they can push bills through. And they've been doing that for the last almost 2 years now. There's only a 2-seat majority in the House and a 2-seat majority in the Senate. Right now, the House is up for re-election November 5th. If you are not registered to vote, please do so. Get out there and vote. No reason absentee ballots and 9 days of early voting. There's no excuse not to vote. But the House is up for re-election. If the Republican majority takes back the House, it will create this, could create this sense of urgency on the part of the Democratic majority. There's what they call a lame duck period. From the point after the election to the end of the year, there's that period of time before the new House takes over, and they can ram things through if they want to. Now, up to date, these bills were introduced last year on November 8th, and they have yet to have a single hearing. So I'm not exactly sure why. Maybe the bill sponsors just kind of wanted to toss it out there, kind of put some feelers out, see where people are. Maybe they decided that during an election year this was too risky to bring these bills up. I'm not really sure what the reasons are, but they haven't had a single hearing yet, which is good news. I mean, that's a good news. And maybe they're just going to let these things die a quiet death, because if they don't get passed by December 31st, they die, and they would have to be reintroduced again. But now I mentioned Democrats, Republicans, and I do want to make it very clear that these issues are bipartisan. This is not an R and a D, like a lot of other kind of conservative things are. These bills very likely don't have full Democrat support, and actually, I can tell you because I've met with all of the Republican senators, I had to convince a couple of Republican senators that these are really bad bills. He wanted personal autonomy. He's very libertarian. He's like, if my time's up, I want to be able to check out. And I had quite a frank conversation with him, and I gave him all the reasons, which Jason will get into later, of why these are bad public policy. And he has now changed his mind. But it takes conversation. So I wanted to mention that because if you've got Democrat family members, Republican family members, you want to talk to them about these bills, because this is really quite, it isn't cut and dry, red versus blue, R versus D. We can't assume all Republicans are against these bills. We can't assume that all Democrats are for these bills. We also know that blacks and Hispanics, which by and large, I don't like to be a monolith, but by and large they vote more Democratic, but they also tend to be less likely to choose assisted suicide. And in fact, the Oregon numbers would show that minorities do not choose assisted suicide when it's offered as a general rule. It's very, very small minorities. So they realize that they've been marginalized in the healthcare system, and they see the dangers of assisted suicide drugs being available. So keep that in mind. I would be remiss to not talk about the intersection of allies to defeat assisted suicide bills. Right to Life of Michigan has joined with a coalition of other interested groups. We are now calling ourselves the Michigan Alliance for Ethical Care. Sounds very benign and lovely. And in this coalition, in this alliance, we have people that we do not see eye to eye on. Right to Life does not see eye to eye on a lot of other issues. In fact, some of these people are very much pro-abortion, for example. Some of them are very pro-LGBTQ, for example. But it's really interesting how you can have interesting bedfellows when you all have a common goal. So just keep that in mind, that this group to defeat the people who are opposed to assisted suicide bills often include disability rights groups, religious organizations, pro-life organizations, elder rights groups, and the proponents of these bills, the people who are really pushing these bills, are the 4 W's, to steal from Jason. Sorry, are you going to go over that? I'm okay. I'm just going to leave it for you. It's great. They're white, wealthy, well-educated, and worried. The 4 W's, white, wealthy, well-educated, and worried. Those are by and large the people who choose assisted suicide, and they are by and large the people pushing assisted suicide. Which I want to go back to this bill sponsors, and I think this is very interesting. There's a 4-bill package, right? 2 of the bill sponsors are people of color. Mary Kavanaugh is Hispanic, and Sam Singh is Indian. So I think that's very telling that the proponents of these bills went out of their way to make sure they had a pack of bill sponsors that kind of fit that profile, so to speak. Real quickly, I'll get into some statistics and then I'll be done. We don't usually talk about other countries because they'll all say, well, you can't compare apples to oranges. We don't have public health care like they do in Canada or in Europe, national health care. But I would be remiss to not talk about our neighbor that's literally just across the river, right, or the lake. Canada is like, wow, something else. There's a group called Compassion and Choices that is really a national organization that is pushing states to adopt assisted suicide bills around the country. They've been very active in Canada, and boy, did they get their way. Canada legalized assisted suicide in 2016, so within the last 8 years. And in 2022, there were 13,102 Canadians who took advantage of what they call MAID, M-A-I-D, medical aid in dying. They used a combination of assisted suicide and euthanasia in Canada. That number equates to 4.1% of all the deaths in Canada were from assisted suicide or euthanasia. Wow, that is staggering. They are like they have the highest rates of euthanasia in the world. Highest rates of euthanasia in the world. And euthanasia for mental illness. You don't have to be sick. You don't have to be terminally ill. It was approved for mental illness. Now, there was such an outcry from the public that they've tallied that off until 2027. So starting in 2027, if you're a Canadian and you've got some mental illness, you can go and be euthanized. Scary thought. I don't like to go down the slippery slope angle, but I just need to go down the slippery slope angle for a minute. 20 states in the United States, 20 different states in the United States had assisted suicide bills introduced this year, this term. Only 1 state has adopted those. They passed in Delaware. Interestingly enough, the Delaware governor asked that they not be sent to him. He wanted them studied by some attorneys before they got sent to him. And really what he meant is, I need to take the political pulse, probably. They just got sent to him. He's got like 3 days left. And in Delaware, it's different than Michigan. In Delaware, if he does nothing and he doesn't sign them after 10 days, they become law. In Michigan, after 14 days, if they don't get signed, they get pocket vetoed. So we are watching very carefully what happens in Delaware. If they get approved there, it'll be the first state in the last 2 years that has had assisted suicide legalized. It would make it the 11th state plus the DC. So a couple quick things I wanted to mention. Again, the slippery slope argument, which we are not going to probably use, but I just wanted you to be aware of a couple of things. In European countries which have legalized assisted suicide and euthanasia, minor children can be euthanized at the behest of their parents, and death by donation is now occurring. And it's exactly what it sounds like. You want to go in and be euthanized, but you want to donate your organs in the process, so they basically kill you by taking your organs out. That's happening. Why waste them? I mean, that's their theory. Another thing that's being encouraged, and I actually saw a webinar, these are medical students who are being taught this by medical ethics. Voluntarily stopping eating and drinking, VEZ, how do you say that? VSED, voluntarily stopping eating and drinking. What they're basically saying is, in states where assisted suicide and euthanasia is not legal, if you really want the doctor to hasten your death, just stop eating and drinking, and you'll then have the symptoms of dehydration and starvation, you'll be in pain, and then the doctor's ethical requirements to treat your pain will kick in, and that will hasten your death. That's literally being taught to some people. And of course, it's agonizing to die of dehydration and starvation, which is again a ploy to have euthanasia as opposed to assisted suicide. And then lastly, just for sensationalism, the Sarco death pod is a real thing. It's literally what it sounds like. It's a pod that you climb into, you close the lid, and then you push a button, and it fills with gas, and you die. And that just got rolled out in Switzerland. The first person who was scheduled to die by the Sarco death pod was supposed to be in July, but the Swiss government, through pressure or whatever, put it on hold. But this is literally the culture of death that we're living in, and we've got to defeat these bills. Even if they die this term, they will come back. These guys are not giving up. So we need a very well-educated populace to understand why these bills are so very dangerous. And I'm hoping that you will be our little army here. So thank you for your time and attention.
While we have a little break, I'd like to know, where are you from? Are you from St. Francis Parish? Raise your hand. If you're from St. Thomas Parish. How about St. Mary's? St. Mary's? you do both. Like me, I do two parishes, right? I tell people you can go to as many parishes as you want to. You just have to decide where you're going to be buried. There's only one funeral mass, right? So register at that one. Christ the King Parish, that's right. Mine. Others? Dexter?
St. John, St. Joe's.
Yes, St. John the Baptist, beautiful.
Christ Our Light.
Christ Our Light, where from?
Troy.
Troy, of course, yes.
Used to be St. Allen's.
Very good.
St. Martha's, Oakness.
Okemos, St. Martha Okemos. I remember when it was built. Good. So at this point, I believe we have Attorney Jason, Associate Director of the Patients' Rights Council. Thank you for coming.
Sure.
Yes.
Space for questions.
Sure.
Oh, yes.
Sure.
Yes, definitely.
I forgot to talk in the microphone.
That's right. Yeah, at the end of the three presentations, Genevieve will answer all your questions. Yeah, since you took everything I was going to say. All right, that's fine. Yes, I'm Jason. I'm an estate planning attorney. I've graduated from Ave Maria Law School in the first class when it was still here in Ann Arbor, and I have been practicing since 2003, 20 years of practice, primarily in estate planning. And then for about 10 or so years, I've been working with a nonprofit called the Patients' Rights Council, which has been devoted to a patient's rights to compassionate care, particularly at the end of life, and dedicated to opposing the spread of assisted suicide and euthanasia. As Genevieve said, euthanasia is not really an issue here in America. What we're primarily talking about whenever this issue comes up, it's always assisted suicide, right? By definition, intentionally, knowingly, and directly providing the means of death to another person so that that person can use those means to commit suicide. And particularly what we're talking about is doctors being allowed to write terminal prescriptions for their patients to kill them. Let's be blunt about this. What I'm going to be talking about tonight, and I normally give an entire 45-minute to an hour presentation on these types of things. I've only got 10 minutes tonight or so, but I'm going to talk to you about some of the reasons, the sociological reasons why we should be opposing assisted suicide and recognizing it for the threat that it is. I often speak in churches, but not exclusively. So the reasons that the Patients' Rights Council has always talked about, what we write about, what we articulate, they're not primarily religious reasons. I realize that we're speaking in a church here tonight. The vast majority of us here are probably Catholic. I'm Catholic, but you're not going to hear me talking about the Vatican's declaration on euthanasia and dying. You're not going to hear me citing things regarding the redemptive power of suffering or Salvifici Doloris or any Vatican document on this. I'm talking about the fundamental common sense societal reasons why assisted suicide is bad. So let's go through some of them. And these are just, the top 10, if you will, the top few. First of all, primarily coercion and pressure. The mere existence of legalized assisted suicide has a coercive effect on the medically vulnerable. As Genevieve mentioned, we are allying with a number of people around the state who are concerned about these 4 bills that are in the Michigan Senate. Who's concerned about it? The disability rights community. They are prominently represented on this coalition precisely because they know what it's like to be marginalized. They know what it's like to be looked at as having a life that is, less worthy of living than the rest of us. They know what it's like to not get the medical care that they want and need. And the mental shift that takes place in a society when assisted suicide becomes the norm means that people are not going to be focusing on therapeutics. They're not going to be focusing on pain control. They're not going to be focusing on helping people with disabilities lead normal lives. They're going to be focusing on making the death process more efficient. I'll talk about that in a minute. But the idea is that we're in a very performance-driven society. America has always been that way. It's our blessing and our curse. We're always on the go. We're always trying to achieve. We're always trying to do something. Patients who are already vulnerable to suggestions to get out of the way, the availability of assisted suicide makes it much more likely that they are going to choose. And how free is a choice like that? Right? When you're not getting the pain control you need, when you're not getting the assistance that you need from your doctor to live a good life. What's he doing? He's saying, well, if you want to take advantage of Michigan's new assisted suicide law, I'll help you. That's not what they need. The pressure is real, the coercion is real. It threatens those with disabilities, it threatens those with medical conditions, it threatens the elderly, right? And that's my second point, elder abuse. The statistics show that elder abuse is an increasing problem in American society, and Michigan is no exception. Our Attorney General a couple of years ago actually just created a brand new division dealing explicitly with the issue of elder abuse and exploitation. I've actually had occasion to use them for one of my clients. We had to work with the AG and prosecute a guy who was exploiting an elder friend of his. But the issue of elder abuse, and it takes all different kinds of form, right? Financial abuse, sexual abuse, physical abuse, mental and emotional abuse. How does legalized assisted suicide mix with elder abuse, right? Genevieve talked about the idea of the tired caregiver. So you've got grandma who's been struggling, and she, like so many other people, has requested and received those drugs for assisted suicide, just in case her situation gets so bad that someday she may have to take them. She's not ready to take them now. Her grandson, who has been living with her for the past year or so because he can't keep an apartment on his own, but he's volunteered to take care of grandma. And he dutifully every night brings her dinner, and that's pretty much all he does, and he watches TV and plays Nintendo Switch or whatever else he does. At some point, he just can't take grandma's suffering anymore. It's too much for him to bear. And he knows that she's got those pills that she requested from her doctor in the medicine cabinet, just in case. And he decides that he's going to mix those pills in with grandma's applesauce that night. And she can't taste it. She doesn't know what's happening. But because she went through the proper legal channels of getting the drugs, because no doctor needs to be there to provide accountability when the drugs are actually taken, nobody knows what actually happened. She just died in her sleep that night. Yeah, because of the 96 pills of phenobarbital that you put in her applesauce, but nobody knows. And I guarantee you these things have happened already. There have been numerous cases, the inquiries in Oregon, looking into this. Not provable. Can't prove it happened, but I'll bet you it did. Third reason, cost control. You make assisted suicide a legitimate medical treatment, guess what? It becomes just like any other medical treatment, except it's always going to be the cheapest. And we already have many examples of patients who have requested life-saving drugs from their doctors and or their insurance companies and been denied the life-saving drugs that they need, but they have been offered that their insurance company will pay for the drugs for assisted suicide under Oregon's Death with Dignity law, or California. The two primary examples that had a lot of high profile, one's in Oregon and one's in California. I normally tell the whole stories about it and build it up, and it's a really great thing, but I don't have time for that right now. But trust me, cost control is an absolute problem. Whether you're a supporter of socialized medicine and government-run healthcare, or you're a supporter of the profit-driven system, either way, money matters. And either way, assisted suicide will always be the cheapest option. The inertia of cost control is going to move people towards acceptance of this. Another problem, and this one's a little more nuanced, so follow me here. The concept of a new standard of care. I alluded to it before, right? What starts as an option for some people, because that's how they promote this, right? Assisted suicide, it allows you to take advantage of this. It allows you to pursue medical aid in dying or death with dignity, whatever the heck else they want to call it, right? It starts as an option for some, but it rapidly becomes an expectation for everybody. A colleague of mine who's no longer in the business anymore, but Rita Marker, she and I used to tag team and speak about this stuff around the country. She was quite a bit older than me. She was well into her 80s, and she used to be able to talk from firsthand experience about when the driving laws changed in her state. She remembers when they first introduced the idea of being able to make a right on red. She remembers back when a red light meant red light, you don't go. I don't care if you're going left, straight, right, it doesn't matter. If you have a red light, you cannot go. And she remembers when they introduced the option, if you wanted to, you drive up, red light, you stop, you look, and if nobody was coming and you deemed it safe to do so, you were permitted to make a right-hand turn on red. What happens now if you decide not to exercise that right? Yeah. Every car behind you leans on their horn because they expect you to make that right turn. It's merely permitted for some who want to do it. But societal pressure is to the point where everybody expects you to do it. And that is exactly what happens with assisted suicide. That is exactly what happened in 2014 when the British Parliament was considering approving an assisted suicide bill for the entire nation, and they brought in Professor Theo Boer, a Dutch academic, high-profile medical ethicist who had supported Holland's euthanasia and assisted suicide law. He was a proponent of it. He helped get it passed. And 10 years later, he's turning around and testifying in the British House of Lords saying, do not repeat our mistake. And why? He changed his mind after seeing years of the boundaries of Holland's euthanasia and assisted suicide law expand and expand to increase and accept more and more and more types of patients, all while the number of cases dramatically increased every year. He says that the very existence of their law turns assisted suicide from a last resort into a normal procedure. And similarly, we saw in the Netherlands, I forget what it might have been actually Amsterdam. They realized that after 15 years of legalization, the whole city of Amsterdam, of 1 million people, only had 2 tiny little hospices to take care of the dying for the entire city. Why? Because everybody is expected to just end their own lives. Don't think it can't happen here in America. I realize the mind shift is not here yet, but that is where we are headed. Every state that accepts this moves the entire nation's mentality closer to saying that this is the preferred normal way of dying. Mistakes. A 2017 study done by the Mayo Clinic in Rochester showed that more than 20% of patients who sought a second opinion at the Mayo Clinic had received mistaken diagnoses the first time around. That's why they went to Mayo to get that second opinion. 20% of patients had a mistaken diagnosis first time around. So what happens to the person who receives one of those mistaken terminal diagnoses, right? They're feeling very vulnerable. They're coming face to face with their own mortality. They're realizing, oh my gosh, this is it. I've got the big C. I might as well just do what everybody's telling me to do and just get those drugs, because I know that at some point my condition is going to get me to a point where I can't stand to be alive anymore. Everybody tells me the pain that I'm going to be in, the suffering that I'm going to be going through. I need to get these drugs right now. We've got high-profile examples of people who have gone to the Dignitas clinic in Switzerland to kill themselves, realizing afterwards in the autopsy that they didn't even have the condition that drove them there to begin with. All right? Mistakes happen, but there's no coming back from assisted suicide. You make that decision based upon a misleading diagnosis, that's a mistake that's going to end your life. And finally, this doesn't affect everybody in this room, but it's a reality, particularly for Tony, who's going to get up and speak next. The issue of conscience protection for doctors and nurses and pharmacists and other healthcare providers who don't want to be involved in this, right? The medical journals have been calling for years for the elimination of conscience protection for doctors in Canada. One of the reasons the bill passed in Canada, it was precisely because the safeguard, as Genevieve talked about, was put in there, providing that conscience protection for doctors. Doctors were wildly opposed to this until they were pacified by the contents of the bill saying, if you don't want to do this, you don't have to participate in it. And just 5 short years later, a court in Ontario decided that doctors must refer their patients to a doctor who will provide the lethal prescription. Well, for doctors who don't want anything to do with this, for doctors who have an ethical problem with assisted suicide, having to provide a referral to a doctor who will do it makes them complicit. They don't want to do this at all. They want nothing to do with it. They want to help keep their patients alive. Not anymore, not in Canada. Because Canada has now made the shift, and they see that the right to die is in fact what I just said, a right to die. And as soon as something is a right, nobody else is permitted to deny it to you. So forget about doctors' conscience protection, forget about nurses who don't want to be involved in this, forget about pharmacists who don't want to fulfill these prescriptions. As soon as assisted suicide is seen as a right, nobody will be able to stand in the way of a person exercising that right. That's how rights work. And that's the language that they're using. They get these bills in front of the legislatures, and they've got all these safeguards put into it to make it sound reasonable, and it's only going to be for the desperate people who actually need it. And then they turn around, like they have done in California. 3 years later, they turn around, and they remove the safeguards because they now call them barriers to care. I'm not making this up. This is the terminology that the other side actually uses all the time in this. You can look at this up. This happened. We watched it happen in California. How they made the bill palatable to people by putting all of these safeguards in, and then they turned around and they called those very same safeguards barriers to care. And all that has all changed now. And the door is wide open in California for assisted suicide. In Oregon, by the way, which is the state where it's been legal for the longest, there is an appalling lack of safeguards and poor record keeping and statistics. You have to remember that when they talk about the statistics for assisted suicide in Oregon, every single one of those statistics comes from voluntary reporting. By whom? By the doctors who are already engaged in assisted suicide. There are high costs right now. Everybody's concerned about money. They always are. So, the state of Michigan has decided that to save money, we're going to pull state troopers off the highways, and we're not going to monitor people speeding anymore. But we're going to rely on the ethical and responsible drivers of Michigan. If you drove to come here tonight from Ann Arbor or Lansing or wherever, and you exceeded the posted speed limit, just call this 1-800 number and let us know, and we'll send you the appropriate fine, right? Voluntary reporting by the people who are complicit in it doesn't work. And yet these are the statistics that we rely on out of Oregon. The proponents of assisted suicide say, look, it works great in Oregon, there's no problems. Well, of course there's no problems. There's no reported problems. You think a doctor who's made his livelihood with assisted suicide is going to report when his patients experience side effects and complications? Okay, it just doesn't happen. So the statistics are not reliable. However, since they're all we have to go off of, remember this. Requests for doctor-assisted suicide in Oregon are almost always based on the concept of autonomy and loss of dignity. Okay? Because the other side, the promoters of assisted suicide, they get a lot of mileage talking about the suffering of patients and how the suffering people need this as a method of self-deliverance. But even in Oregon, shoddy though those statistics are, they tell us that the vast majority of people who are requesting assisted suicide are not doing it for pain reasons. They're not doing it because they're experiencing this difficult and debilitating pain. They're doing it because they fear the loss of being able to play tennis. All right? And this is just not me being scornful. These are actually what the statistics show. The top 4 reasons given every single year in Oregon for why people request those assisted suicide drugs, why they get those lethal prescriptions from their doctors, they all have to do with loss of autonomy and dignity. Fear of not being able to do the activities that make life enjoyable. Fear of loss of dignity. Oh, that's exactly it. Further down the list, usually number either 5 or 6, depending on the year, it's pain or fear of pain. They're conflated in the same thing. Everybody fears pain. I fear pain, okay? That's a reason why people might pursue and get lethal prescription in Oregon. Pain or fear of it. So don't trust the statistics. All right, I know I'm over time, sorry about this. So the last thing I want to talk about is protecting yourself and your loved ones. If, God forbid, these bills pass, you know what? Whether or not these bills pass, the mentality is there. So, everybody is best protected by making sure that you have in place a durable power of attorney for health care. If you do not have one, make an appointment with your lawyer and get a durable power of attorney for health care, naming a trusted person to make your medical decisions for you if you become unable to participate in them yourself. These are the sorts of conversations I have with my clients all the time in the context of estate planning. You may or may not have this happen to you, but a surprising number of people experience that level of debilitation, either temporarily or permanently, where you lose the capacity to make medical decisions for yourself. And if that happens and you find yourself in the hands of a pushy medical establishment that needs the bed for somebody else they think is more worthy, the only thing that's going to prevent you from becoming one of those statistics is your agent, the person that you've named in that medical power of attorney document who's going to be able to stand up for your rights. So again, regardless of whether these 4 bills in Michigan Senate pass, and I hope to God they don't, but whether they do or they don't, make sure that you've protected yourself and your loved ones. Every adult in your household should have a medical power of attorney identifying a trusted decision maker. So, I'm way over time, I'm sorry. Come on up, you're next, Tony.
Wonderful. Wow. You have to set the stage because our imagination doesn't understand how serious this is until we get to meet the facts, right? So thank you for doing that. Now, Dr. Anthony Gretsch. Tony Gretsch, right? Very good. Hospice and palliative medicine internist. Welcome.
Yeah, thanks a lot. Whoop, what's going on? Oh. There you go. I'll pull this one off. All right. So thanks so much for inviting me to come out. My name's Tony Gretsch. I'm a family physician by training, but the last 10 years I've worked solely in hospice and palliative medicine. And I do that really because what I've recognized is nobody actually needs help dying. It turns out that every one of you, myself, and everyone else that's walked the earth, save Jesus, will die 100% of the time completely effectively. The catch, the reason that I'm here, the reason that I'm a doctor, is not because I need to help you die. It's actually because while you're dying, most people need help living. Most people forget that even though you're dying, you're still alive, and you might need help being able to experience that life the best way that you can. It may look different from how it was before. You may not be as active. You may not do those same things that you always did, but you're alive. Why would you waste it worrying about just your death? I want you to experience your life. So that's why I do hospice and palliative medicine. And now I also work out in the Port Huron area taking care of very frail elderly patients, most of whom have a life expectancy somewhere in the 3 to 4 year range. And our job is to try to help keep those folks in their homes, not ending up in nursing facilities. So I was trying to think how I can pare down the ethics of assisted suicide into about 10 minutes. When it comes to medicine, it's pretty hard to do. So I'm gonna summarize a little bit and try to highlight one or two points that I think are really important. And I'm going to start with two truths and one lie. That first truth is going to come from something that St. Pope John Paul II once said, and that is that we are each a unique and unrepeatable soul. If you think about that, that means that we each are intrinsically valuable. Your life will never be lived again. You are rare, you are precious, and so you're valuable, right? The next truth is the definition of dignity. This is the state or the quality of deserving honor and respect. There's no other way to define it. You're so valuable that you deserve to be treated with dignity, with honor, and with respect. And that brings me to the lie. And that lie is that assisted suicide or euthanasia dignifies your life. I fail to see how ending a life before it's naturally intended to is honoring that life or respecting that life, which is intrinsically valuable. So what I'm going to get into are 4 problems that I see from a medical perspective. Jason did a fantastic job highlighting numerous problems. I'm going to touch on just 4 that I think help explain it from a medical ethics perspective. Right, so the first problem is the whole notion of death with dignity, and that assisted suicide dignifies life. Well, it doesn't. It actually ends it. It's disrespecting life. That is the opposite. That is indignation. That is not dignity. That's the first problem. It's an interesting play on words, and words are really dangerous. The second problem I see is the notion or the assumption that ending our earthly life relieves suffering. For those of us that have any belief in life after death or eternal life, it's not so hard to imagine that you might do things that actually could cause suffering after this life, and that might actually last an eternity. Now, for folks that don't have that same belief, that's okay, but they also cannot guarantee that there's no life after this death, and they cannot guarantee that by ending their life, they're ending their suffering. Perhaps I've just made your suffering worse for eternity. The third point gets at that slippery slope that we've heard about a couple of times tonight. So in order for assisted suicide to be okay, we have to have a false assumption. And that assumption is that life has the ability to lose its value. That means value is not an intrinsic property of your unique and unrepeatable soul. So where does that value then come from? That value must then come from what life can do, the productivity, your ability to contribute to society. That value perhaps comes from your ability to experience pleasure, whatever we think that pleasure is supposed to be. And when you're no longer able to produce to help further society, or you're no longer able to experience pleasure, whatever that might be, then life has lost its value and you're justified in ending it. Well, here's where that slippery slope really gets dangerous, and that is if you carry on and allow that to progress down towards its natural conclusion, it becomes really easy then to justify coercing and forcing people who are no longer productive, no longer able to experience pleasure, to end their life. And so now the disabled, the elderly, the unborn, which is interesting how abortion started as something that was supposed to be rare and infrequent, that is now so prevalent and pushed. Assisted suicide will do the same thing. And it's because of that notion, or that assumption that your life can lose its value. So that's the slippery slope, but that's actually not what I'm going to touch on the most here. The most important point from a medical side of this is actually that assisted suicide robs the patient of the ability to experience healing. That is a massive problem for me as a physician who took an oath to always heal. If I end your life before it was supposed to end and you were suffering, there was some healing there that did not take place. That there's a good chance that somebody like me and a team that works to take care of people that are suffering that way never had an opportunity to heal you. Why do people pursue or seek assisted suicide? Jason touched on it and clearly emphasized it. It's really because people lose their sense of meaning, right? So 90% of people in Oregon between 1998 and 2022 sought assisted suicide because of a loss of autonomy and inability to do the things they once enjoyed. They've lost their sense of meaning and purpose in life. That is, if you've ever experienced a midlife crisis or a crisis of any sort, and any kind of existential crisis, it's painful. It hurts. It's agonizing. That is real suffering. When you've lost your sense of meaning, you will be suffering. There's no getting around it. But I look to somebody like Viktor Frankl. If you haven't heard of him, he is a world-renowned, now deceased, psychologist who survived the Holocaust. I forget which camp he was in, but he survived. And his entire life after that was about studying, explaining, and healing people who've lost meaning. It's about man's search for meaning in life. He was able, while he was in a concentration camp, to still find meaning to carry on each day. One of his quotes is, "For the meaning of life differs from man to man, from day to day, and from hour to hour. What matters, therefore, is not the meaning of life in general, but rather the specific meaning of a person's life at a given moment. Meaning is not static. It is fluid. Your meaning and your purpose in life changes as your life changes. The meaning for a young adolescent is going to be very different for the meaning in life of an 80-year-old person. Yet both will still find meaning. It's just going to be different." What Viktor Frankl taught was that when somebody is suffering from a loss of meaning, your job is not to end their life. Your job is to heal them by reconnecting that person with a sense of meaning. And that is where true healing comes in. If we end their life, there was no opportunity to actually heal it. Also, to touch on something Jason mentioned, that is the fear of pain, or pain itself. I have yet to see a patient in the last 10 years that myself or my team or a colleague was unable to relieve their physical suffering. That's not to say people don't have physical suffering, they do. They may just not have received the best kind of care for that. They may not have received expert symptom management by a physician trained in hospice and palliative medicine, which is actually where we should be putting all of our effort, is actually increasing the availability of hospice and palliative medicine to all the people of the world. But that fear is unfounded. We can treat that pain. So let me get into the actual ethics behind some of this. I'm going to start with the Hippocratic Oath. Okay? The Hippocratic Oath has been around for centuries, millennia. There have been many different translations of it, many different interpretations, but I prefer some of the more original ones. The later ones, especially that are used in most medical schools now, have really been adapted to meet societal norms now. So I don't count those. But if I'm going to summarize the Hippocratic Oath, first, a physician must always seek to heal. Heal always. 2, do no harm. Do not harm anybody. And one of the most interesting sentences in the Hippocratic Oath, especially the original forms of it, I quote, "I will not give a lethal drug to anyone if I'm asked. nor will I advise such a plan. So, in the infancy of medicine, it was actually very apparent to Hippocrates that assisted suicide and euthanasia, though they were not called assisted suicide or euthanasia at the time, they were wrong. That is not something a physician, a healer, should be doing. It is not healing. It is killing. When we look at the actual ethical principles, we think of beneficence, which in the Hippocratic Oath is really always heal, do good, right? Do good things. Assisted suicide is in direct contradiction to that. It harms, it ends life. We look at non-maleficence. Do no harm. Don't do something that's going to be harmful. Assisted suicide harms directly. Assisted suicide may cause more harm if it in fact causes more suffering in our eternal life. And it prevents healing, prevents that opportunity for healing. So now we've crossed beneficence, we've crossed non-maleficence, and then we get into justice, right? Justice is the principle of we need to be fair and equitable, treat everybody as we should treat them. Well, let's think about justice. We talked about that slippery slope. Assisted suicide opens that door based on the false assumption that life loses its value. We've opened the door to coercing and forcing people that are not productive, people that are not experiencing pleasure, people that are marginalized in society, the disabled, the young, the elderly. We are now opening the door to coerce them and force them into death. There is no justice in that. I'll talk about two examples. One is going to be a non-human example, and the other one's going to be a human example. The non-human one is, let's think about fire. Fire is beautiful. Fire is brilliant. It gives off heat, has many functions. But fire dies. As fire dies, it becomes embers. They are not brilliant. They may be beautiful, but not the same way that fire is. They don't give off as much heat. They're dying. They've lost their value. But which one of you would grab an ember? Nobody. Embers are still hot. They still give off heat. And what happens when you touch kindling or paper to an ember? You start a new fire. You give new life. You have now started something new and brilliant, and you've contributed to the world even though you're dying. Let's think about a human example. I'm going to think about a patient that I recently took care of. It's a woman in her mid-70s, worked as a nurse throughout her working years. Wonderful nurse. She took care of her parents that were dying. She took care of her in-laws as they died. She took care of her husband as he died. She developed metastatic breast cancer. She became disabled. She couldn't walk the same way. She couldn't care for herself. She was unable to care for others, and she lost her sense of meaning. And she begged us, my hospice team, to end her life. She wanted a prescription of 10 times more morphine. We were using hydromorphone, but similar medication. She wanted 10 times more of that because she knew that would end her life. With the work of our team, our chaplain, our social worker, our nurses, our home health aides, which are people that go to the home to help provide basic care for people. Through their work, she was able to find a new sense of meaning by teaching others how to be a caregiver, allowing our team to care for her. Our young nurses, our young caregivers, they all learned from her. She had a renewed sense of meaning in life and lived for another 3 months with peace and with joy. That is reconnecting somebody with a sense of purpose. That is healing. The truth is you are all unique and unrepeatable souls. The truth is you all have intrinsic value. You matter, and you deserve dignity. You deserve to be respected. You deserve to be honored. My job is not to help you die. My job is to help you live while you are dying. Thank you so much for letting me speak with all of you tonight.
So we're going to do a Q&A. Do you folks want to come up here, or would you rather sit at the table to do that? Well, the camera will only get them up here, right?
Oh, the camera can go all over.
Okay, so then put that one on the table, and then whoever has a question, maybe raise your hand and we'll go around the room. Questions, anyone? Come on. Okay, well, I had some. Oh, we have one? Okay, good. Speak right into it.
It seems that this particular place that we find ourselves in with the dignity of life has a long history of loss of dignity over the past at least 100 years, I would think, that so much has happened where we've lost respect for one another in so many ways at every step of the way. And so as we look ahead, even as we look at our college students today and see them, and how do we help them? How do we find a way of speaking truth to them that they can grasp, that they're being given such a lie, that they're being given so much information that seems reasonable and seems like it's truth, and yet it is so deceptive. What are we going to do? I feel like our answer isn't in our vote. Our answer is in renewing the truth, living the truth, speaking the truth, and helping our youth and our children come to embrace the truth.
Did you have a question?
Well, how do we begin to accomplish this?
Yeah, that's a fantastic question. I think you actually answered it as you were asking it. And you commented on how we have to set an example, right? And I'd be curious to know if, Jason, you or Genevieve, you have any different ideas on this, but my thought is by setting that example, you're also pointing out to other people who are living with an understanding that their life is valuable and that they deserve dignity. Pointing out that many of the ways of the world and the aspirations of the world haven't actually helped us be happier people, be more joyful people, and point out those that are, and look to their lives as examples. I'm trying to figure out how to do that for my kids. I'm not very good at it. My kids are pretty young. They're 9, 7, 5, and 3. And their happiness, they continue to seek it in the Nintendo Switch. I really hope they don't become the character in your talk, but I really think it's by setting that example and pointing to people who have been good examples of that in the world. I don't know.
Another question?
So this follows up really. It goes to the question of how to engage the culture. I've often thought of what common ground do we have? Is it the moral law? What's the natural law? But I guess what I'm wondering is, are the resources that bring together some of the science, like people say follow the science, but unfortunately they follow it selectively. Okay, so if British doctors determine that the transgender care that they've been giving actually doesn't work, how do we get that message out to people? Similarly with this Dutch doctor that you mentioned, that pleaded with people to look at what happened in Holland. So are there some key scientific facts, or are there books or resources that we can use to help people to know the truth?
Well, in my opinion, I think it's all out there, right? It's just a question of creating occasions for engagement. I've become very cynical about the future of America, unfortunately. I don't know. Yeah, I can't imagine why, right? I've especially in the past couple of months, I've read two separate books, two separate authors, completely secular. One is an economist and one is an academic, and they both have convinced me that we're definitely on the downward slope of the American experiment. If there is to be any societal salvation, it's going to come from the proper formation of the next generation, and that does not happen easily. That happens in intact families. It happens in schools where their peers and their friends also are being fed the same healthy diet of proper optimism and critical thinking and the best of what Western civilization has been teaching for the past couple of millennia. All of the lies that we see in the mainstream media and common culture, they poison people. They're half-truths. They sound good. You said the example earlier about happiness, right? Everybody thinks that pursuing happiness in life is simply the absence of suffering and pain, and it's all about pleasure. A happy life is one that is lived in accord with virtue. Eleanor Roosevelt said it. Great thinkers have said it. A life lived in accord with virtue and value is what actually makes somebody happy. You can't talk about that in the general public because people don't even speak the same language anymore. They think if you acknowledge that some suffering can be good, that some hard experiences in life can actually be good and lead to greater happiness and satisfaction, they don't want to hear it. They want the nonstop pursuit of pleasure and the complete absence of suffering. All of this is cyclical. That we're getting way beyond the topic that we came here to talk about tonight, but I don't have an easy answer for either of your questions. You have an answer? Go ahead.
What we're doing tonight is communicating with people, regular people, with experts. We are recording this. It's going right up to the YouTube for St. Francis, but we will be publicizing this, that this took place with these great speakers. And tell your friends, tell your parishes, take a look at the YouTube presentation on St. Francis's YouTube site. We're also going to promote it to other. This was originally designed to promote to our deanery and then to churches in Washtenaw County. That's why that table has reserved seats for politicians. Those are the state politicians from the state of Michigan, House of Representatives, candidates, and sitting politicians. You can see, well, Barbara's sitting in one of their seats now, but you can see that nobody showed up. Nobody showed up. And so we have to spread the word. We have to spread the knowledge that we get tonight, and we intend to do that by moving this video around. You can do your part by promoting the video and promoting people to go see it.
Will we be able to share it? We will? Okay, good.
You simply go to St. Francis.
Okay.
Mass live, and you'll see it. But to answer your question, sister, what are we going to do? I'm convinced that John 3:16, everybody knows that from the football game, right? Everybody knows God so loved the world that he sent his only begotten Son, right? He didn't come to condemn us, right? Well, today we ought to say, God values you so much, he spends time with you. Right? There's lots of opportunity to spend time with people who are isolated, and isolation is often what leads to this sense of I'm a burden, nobody wants to spend time with me. So why not lighten the burden? And so if we truly believe Jesus Christ came because he values us so much, spend time with people who are perhaps in assisted living, perhaps in hospice. I have lots of opportunities for you.
I just wanted to chime in real quick. The vote is not going to change the culture, but the vote might stop these bills from becoming law next term. So it is important that which will impact the culture. I mean, laws don't change the culture, but they can influence the culture. Like, I'll give you the perfect example. We legalized pot in 2018. There's a pot shop on every corner now. It's a real example. So our laws do influence our culture, and voting is a civic responsibility, and we do need to vote with an informed conscience. That being said, to your point, I want to just share a little optimism. I started homeschooling my children 30 years ago, and I was a freak. There were no homeschoolers. I was one of the only homeschoolers. I was literally called granola by my family. There are homeschooling families all over the place now. There are families who are rejecting this garbage culture. I work with a young woman, very young, and her peers are like, they want to be moms. They want to have children. They're rejecting a lot of the garbage that's being sent to them. And then, here's the other thing, to the mainstream media, it's dead. My kids, my 30-something-year-old kids, they don't watch the news. They are long-form podcast listeners. This is where they're getting their information in many cases. So I guess what I'm saying is these are all signs that there's hope. So we don't want to give up hope. But what can we do? I think the other thing we need to do is, my mother had a stroke. I'm her guardian. I have to take care of her. My father was basically euthanized in the hospital. That's a whole nother story. But we need to constantly point to the fact that right now my mom could be considered a burden. She can't speak, she can't communicate, she has got Wernicke's aphasia, it's very bad. She was a human being, she could do really great things. So I remind my kids, I canned peaches the other day. And I said, my mom taught me how to do this.
One other thing I'd just add, I'll be quick. When you're in conversation with other people, arguing most of the time right now in today's culture doesn't get very far. It turns into a shouting match, and whoever can say the most inflammatory remark. That's true in just about any conversation, whether I'm having a difficult conversation with a patient and family about a poor prognosis, or discussing whether or not it makes sense with a surgeon to do an operation. But one of the most effective things and disarming things can be showing genuine curiosity and just asking, why? What makes you say that? I'm really curious to know. Help me understand. When you get other people to actually articulate what they're thinking, you're either going to find that they're actually just regurgitating information, they actually have no idea what they're saying, or maybe there is a point that's worth exploring more. And that might open the door for you to offer some alternative opinions, or maybe a different view of something. And so I find the most effective form of conversation is simply asking why, or what. Yeah. Greeks.
Yes. Hello, I'm Mitchell Garner. I'm an attorney, and I want to thank our panelists for wonderfully informative discussion here. I'm trying to bring a little bit of optimism to this but I have a saying that you can put lipstick on a pig, but it's still a pig. And these bills in the Michigan legislature right now, that's putting lipstick on a pig to say this is death with dignity. But anyway, I was intrigued by one fact that one of our speakers brought out about the 20% different diagnosis at Mayo Clinic. I mean, that is amazing. I mean, that just shows you that medicine is a science, but it's not always 100% right. And so I think before people go off the deep end, they should ask for a second opinion. And I know Mayo Clinic is very famous for finding hope where people might be lacking hope. The second thing is something every Friday on Catholic radio, there is a guest named Bobby Schindler, and he's the brother of a woman named Terry Schiavo. And her case is very famous, and he has been a longtime proponent of science as improving the hope of people who were considered having no hope at all. And I think that's one thing we need to emphasize, that science is making improvements, that sometimes people who are considered brain dead actually have, if they're given enough time and the proper treatment, they can come back and be productive, or certainly more productive than they were in a comatose state. So I think that provides some hope as well. So both are related to science, Mayo Clinic, the diagnosis, the ability to have a second opinion, and then this advancements in science for helping people who are suffering from brain injuries.
Excellent points, and I'm just going to springboard up what you just said, and this is one of the arguments that we use when we're talking about these bills to people. I personally know several people who were given a 6-month diagnosis. They were eligible for hospice, and you can speak to this better than I will. Give you the microphone. My coworker's dad was told, come down quick, he's in Florida, he's going to die, you've got to get down here right now, right now. They're giving him a week. That was 19 years ago. He went hunting and got a deer a couple years ago.
We are humans and we are fallible. And as doctors, we really should be just trying to speak in terms of what we expect and what would we be surprised by. I can't tell you with 100% certainty what your prognosis is. I can just speak to what I might expect and what I might be surprised by. When we frame all of our conversations in that kind of way, when we're talking about prognosis, that opens the door for people to express a little more about what they'd be willing to risk to try to live as long as they can, or what they really aren't willing to go through to try to extend their life. And so I think it's really important when you get bad news from a doc to try to ask, well, what would you expect? What would you be surprised by? I've taken care of so many people in hospice care who lived for 5 years or more, and I was surprised beyond all belief. But that's okay. I didn't have to be right. I just wanted to give the information, the best information that I had available to me, and that is, most people with your situation, I would expect to have less than 6 months. I'd be surprised if you had more, but I hope you do. Let's talk about what you'd be willing to go through, what kind of treatment you'd be willing to receive to try to extend life, or what kind of treatments you don't want, and you'd be okay if life was shorter. So that just some more ways of thinking about it. But boy, yeah, the second opinion is great. If you go to Michigan, you'll get 30% of people with the wrong diagnosis, and I'm a little biased. I would Michigan alone, but we can't predict the future with 100% accuracy. So when it comes to talking to people about end-of-life care, we're going to be wrong as docs. If you find a doc who's that certain of themselves, find a new one. Just go get a new one. Get a new second opinion.
I want to just real quick, again, jump into what he just said, because I think it's a really important part of this discussion. A lot of people are like, they killed my mother, they killed my father. I get these calls. I actually get more end-of-life calls in my office than I do abortion calls at Right to Life, believe it or not, by far, 10 to 1. But deciding that you don't want to endure painful or tedious treatments any longer, knowing that it will prematurely cause you to die, is not the same as assisted suicide. It is not the same thing. I had an uncle who was on dialysis, and he dutifully went through his dialysis 3 times a week. I think it's exhausting, very tedious. He slept the whole next day. And he finally said, you know what, I'm done. I'm 80-something years old. I've lived a good life. I'm comfortable knowing that I'm good with God. I don't want this treatment anymore. And the people are like, you're going to commit suicide. That's committing suicide. No, it's not. So I just really wanted to clear that point up.
I'm sorry, you just touched a strong chord in me. I might even reframe that just a bit.
Okay.
So, totally fine if folks disagree with this kind of perspective, but when we think about people who are suffering from a severe possibly terminal illness. Right? We have medical treatment right now, and what I always hope is that my medical treatment is going to help you live longer and feel better. But if my treatment's not going to do both of those things, I want to know, which one do you prefer? Which is more important to you? And if it's to feel better, that's okay. That wouldn't necessarily end your life prematurely. Your life is going to end when it naturally would. My treatments might extend your life. It might change the course of how long you have to live, but saying I don't want to go through that because that doesn't sound like something that's going to help me live well. It's not a way that I'd be okay living. I would accept my earlier natural death. Right? So I just want to kind of be clear on that. It's not even saying that you die prematurely. The treatments are actually keeping you alive longer than you otherwise naturally would have. Right? So there's just that kind of minor point, but it's really important. You're not obligated to accept every form of treatment that's going to extend your life. Unless what's most important to you is being alive as long as you possibly can. And what your life looks like doesn't matter as much as long as you're alive. Right, so, sorry, thank you.
No, I think that's really important. I appreciate you saying that, because everybody is going to come at their mortality in a different way. And like my sister-in-law's husband, or father, was diagnosed with lung cancer. They said, with treatment, you can probably live 6 to 9 months. Without treatment, 3 months. He says, you know what? I don't want to spend the last 3 months in the hospital throwing up and being sick on chemotherapy. I'm going to just not have any treatment and let my cancer take me naturally. He lived 15 months. So, yeah.
It's amazing how that works.
Amazing.
Yes, doctor, but my question is real quick. Concerning the hospice care, when we need to call for hospice care, is there a culture within that organization that's adapting to assisted suicide, or is it per individual healthcare caregiver?
That's a fantastic question. So the question, if I can summarize that question, are there certain hospices, or is there a subculture in hospice care that actually abides by assisted suicide and performs it without calling it that? Yes, there is. I gotta watch what I'm saying here. It is important to know not every hospice is created equally. Just like everything else in life, not two organizations are going to be completely the same. What I would look for, if I was pursuing hospice care for myself or a loved one, I would be looking at who's the company that owns this hospice. There may be some companies that are driven more for profit. There may be some companies that are driven more for purpose. I would look for those that are more concerned with purpose. I would ask other people. I would go to your local parish, go to your local community that you trust, and ask who's had hospice care. What was that experience like? You'll find out pretty quickly which hospices are in it for the money, and there are things you can do to maximize your return, and which hospices are in it for the purpose of actually taking care of people who are dying. Those are hospices that tend to do some more things for some more people that profit-driven hospices would not. So I'm trying to answer it as diplomatically as I possibly can. All right.
Hold it right up.
Yes, you do.
Do your due diligence.
You do.
My question is for the doctor. In the last 10 years, have you seen a shift in overall ethics, sound ethics, in the medical profession as well as the professional schools of the allied health?
Yes, absolutely. In both ways, though, in good ways and in bad. So I've seen schools now starting to teach about hospice, about palliative care, and about how to actually have conversations with people about their illness. How to actually have conversations that get at what's important for people, what people value, and what they look for in their life, and align medical treatment with those important things. But I've also seen a shift where there's also teaching on pushing assisted suicide, on endorsing that. I've seen shifts in physicians. Most docs want to do the right thing. They got into medicine not to make money. If you wanted to make money, investment banking is way easier. Believe me, this is not the field you go in to make a mint. So most docs are in it for the right reason, but the powers that be right now that pay for the doctors, they push different things. Your insurance companies, your government-funded medical plans, they push metrics that don't actually pertain to patients. They push metrics on doctors to make sure we're prescribing certain types of medications, to make sure that we're seeing 40 patients in a day when you really can't say any more than, hi, how are you doing? Don't actually answer that question and leave. Doctors are being pushed into this, which is why you see a lot of doctors committing suicide. They have the highest suicide rate of all time right now, and one of the highest across all disciplines, across all fields. That's why you see doctors leaving medicine, because they realize that we're not actually here to treat people, we're here to make the company money. Right? So there is that shift too, but it's not all bleak, because there is more of this understanding and teaching too about actually sitting with people and finding out what matters most and making sure my treatment that I'm offering you is in alignment with what matters most to you. That was a long answer, I'm sorry.
It's a great answer. But it also hit a point for me, just something we forgot to mention. I thought you would, but I forgot too. When assisted suicide is legalized in a state, regular suicides increase. It's called suicide contagion, and we have actual metrics we can measure to say that for sure, like in Oregon, a 6% increase in regular suicides in states where assisted suicide is legalized. So keep that in mind.
Yeah, so I'm actually the president of the Pro-Life Club at Christ the King, and I'm super involved in the fight against abortion. I've done hundreds of hours of outreach, and in the battle against abortion, there's very clear apologetics that you can use. So famously, Scott Klusendorf developed some very good, very good apologetics that you can follow. Human rights argument, like try out the toddler, all of these strategies to change public opinion on abortion. And I'm wondering if a similar thing is being developed, or if you could come up with something clever that could change public opinion on these topics.
Darn, I don't have a SLED example. I would love to have an acronym like that. I might have to come up with something. There are materials up there, and they have some great arguments why assisted suicide is wrong for society, wrong for people, bad public policy. But I will caution you, and this is, I mean, I do this for a living. I work in the abortion world, right? This is literally what I do. But we try very hard not to conflate the two issues, because like I had earlier said, I think you missed it earlier, the people, the coalitions who will oppose assisted suicide, in many cases, do not have, they don't find abortion to be a problem. And we do need to partner with those people to defeat assisted suicide legislation and the creep into our society. So be careful not to conflate the two issues, because they are, unfortunately, different in the minds of a lot of other people. To us, in this room, we're like, it's life, don't kill it. But, you know.
For those of you who might have come in late, over on that table, we do have handouts that have a lot of good talking points. So I sent your friend over to get some, so. Another question? Okay. Put it right up to your mouth. Right up to my mouth.
Okay. Hi. I have a feeling that we already are experiencing the slippery slope a little bit, which I didn't hear you guys touch upon it a little too much, but like in healthcare facilities, nursing homes, even in hospice, which I don't know too much about. But since probably the late 80s, I come from a very large Polish-German family, so I've lost all my grandparents, great aunts and uncles, and just this past year I've lost two uncles who their last days were at the VA hospital here in Ann Arbor, and I got to visit them. And not a single situation, being a niece or a granddaughter or whatever, did I have any say in any medical decisions. But my mother, who is extremely pro-life, and my family, we got the sense in many of these situations, even going back to the late 80s, that several of these deaths were sped up with drugs. So that's why I'm saying I have this sense, I actually work in healthcare, but that there is already a slippery slope especially with the elderly, that is not just about deciding not to receive advanced medical care or whatever, it's when the time is convenient. And my grandfather, who died several years back, he was 96, he would have been close to 97. He had a sister who lived till she was 100. But we visited him up north, mid-Michigan, at the nursing home, and when we got there, because we heard it was coming to the end, he was talking that evening, and then a nurse came in and said, okay, so-and-so, it's time for your morphine, but earlier he had said, I don't want any morphine, but the decision was taken away from him, and we had left and gone home, several of us, and my dad and my brother had stayed. By the end of the night, he had died, and we all had a strong feeling that had he not been given the morphine and the other drugs, he could have survived weeks, months, or whatever.
Sure.
So I get this feeling that we already are in the slippery slope, especially with the elderly.
So, that's a really good, I think that's a really good question and a really good concern, a real concern. I could talk for probably 5 hours on this topic, but I'll try to condense it down here into less than 60 seconds. There are some myths about medications and opioid medications, especially at the end of life. I will tell you, there are times when wrong doses are given, when too much is given, and that can cause somebody to come to the end of life sooner. However, I will also say, most of the time, those medications have no effect on how long somebody has to live. If dosed properly, dosed to treat the symptom, to relieve the distress by that symptom, it's not going to cause somebody to come to the end of life any sooner than they otherwise would have. There are very rare times that I've seen. Now, I'm only one person, and I know the way that I practice medicine, so there might be some facilities and doctors out there that use too high of a dose. But I am very positive that the vast majority of docs and the vast majority of hospitals, when they're taking care of dying patients at the end of life, are using appropriate doses of opioids, using appropriate doses of other medications that are going to help relieve anxiety and agitation and shortness of breath. The trouble is, there's a lot of misconceptions that no, morphine's going to kill you. Oh, I'm starting on hospice and I'm going to put somebody on morphine until they die. Well, starting on hospice, and if they're having pain or shortness of breath and they're having a hard time swallowing, it's really hard to give somebody Tylenol and Motrin. You can't swallow those tablets. But what we can use are small concentrations of liquid morphine in the right dose that is going to be easy to put under the tongue, easy to put between the cheek and gum, easier to swallow, that should relieve that pain or relieve that difficulty breathing without hastening somebody's death.
We could do a whole seminar on end-of-life care and concerns like that. Really, today's meeting was really to talk about the dangers of assisted suicide per se, and maybe you guys want to schedule another, conference on appropriate end-of-life care, what we can talk about. Like I said, I get more end-of-life care calls in my office than I do abortion calls, and we've actually developed like a patient checklist. And to Jason's point, everybody in here should have a durable power of attorney for health care, period. Right to Life, RTL.org, you can download it, you can print it. You don't actually need an attorney, though Jason is wonderful, and I would strongly recommend him. He's fabulous on all kinds of things, but you don't actually need an attorney to fill out a durable power of attorney for healthcare. You need 2 witnesses. It doesn't even need to be notarized. So keep that in mind, get it done, and that's going to be your best protection.
Okay, we want to thank our panel, give them a nice round of applause. Thank you so much. We want to thank all of you for coming tonight. And just so you know, this event was co-sponsored by St. Francis and St. Thomas. And St. Thomas has a Respect Life Committee that meets the second Thursday of every month at 3:15 in the parish library. Anyone in our deanery, any Catholic church in our deanery, which are the 6 parishes in Ann Arbor and Ypsilanti, you're welcome to join us. We'd love to have to move to a bigger room. Okay, and thank you all for coming.
We did that